All right. Hi, everyone, and thank you for joining us for today's Department of Medicine Grand Rounds. I want to introduce our speaker. Dr. De Boer is a professor of medicine, associate director of the Kidney Research Institute, and adjunct professor of epidemiology here at the University of Washington in Seattle. Also staff nephrologist at the Puget Sound Veterans Affairs Healthcare System, where he cares for patients with a broad range of both acute and chronic kidney diseases. Dr. De Boer's research focuses on the causes and consequences of diabetic kidney disease, on which he has published over 300 manuscripts in the field. Dr. De Boer has helped us translate research to clinical care through clinical practice guidelines, including the ADA Standards of Medical Care in Diabetes, as a member of the Professional Practice Committee, and the KDIGO Clinical Practice Guideline on Diabetes and CKD as co-chair. He currently serves as the deputy editor of the Clinical Journal of the American Society of Nephrology. Thank you so much for agreeing to being here with us today and for sharing your expertise and knowledge. To the audience, please do ask questions throughout via the chat. We'll both be monitoring that and hopefully get some time to answer some questions at the end as well. Thanks so much.
Thank you very much, Johnny, for the very kind introduction. It's really a pleasure and an honor to be here presenting at Medicine Grand Rounds. I've presented here once before. I realized 10 years ago, almost exactly a decade ago, and I presented at that time about diabetic kidney disease. And so it's a real joy to summarize here what we've learned since in that 10-year period of time. I do have some disclosures listed here. The most relevant ones are I have consulted for 2 companies that make diabetes drugs, specifically SGLT2 inhibitors that I'll be talking about. And since I have the podium, I actually wanted to start just with a thank you to everybody who's been taking such great care of our patients during the pandemic. It's a very challenging situation, and I have so much respect for all of the faculty and staff and house staff who've done a great job with COVID. I'm going to move from the pandemic to the epidemic of obesity and diabetes that we've had for some time, of course, and very briefly go over some of the epidemiology about that and how it's leading to kidney disease in this one slide. So on the left of this slide is a map of not of COVID incidence because the rate in Australia is too high there. This is the prevalence of diabetes worldwide, estimated by the International Diabetes Federation. And it's anticipated that there will be 700 million people with diabetes in 2045. And in some data that we've generated and others have shown here in the middle and from NHANES, the prevalence of diabetic kidney disease is increasing in proportion to the underlying prevalence of diabetes, with now over 8 million people in the United States with diabetes and chronic kidney disease. And on the right are data from the United States Renal Data System Survey, which shows incidence of, this is prevalence of kidney failure due to various conditions, and shows that diabetes is the most common cause of end-stage kidney disease in the United States, accounting now for about half of all new cases of kidney failure. Not shown on this slide is also that people with diabetes and chronic kidney disease are very high cardiovascular risk and high risk of premature mortality. So today, what I hope to go over are the foundations of diabetic kidney disease prevention and treatment. I'll talk about the new evolving standard of care for people who have diabetes and chronic kidney disease based on exciting new data and is emphasized in new clinical practice guidelines. And I'll talk a little bit about the future of diabetic kidney disease, including emerging therapies and how we can bring precision medicine to advance the field of diabetes and chronic kidney disease. And like Johnny said, I do hopefully have time to answer quite a few questions. I'll try and keep an eye on the chat box. So if you do have a question to ask during my talk, please put it in there and I'll see if I can see it real time and address it. Otherwise, hopefully we'll have time for discussion at the end. I'm going to start with a patient from my clinic at the VA. This is a 69-year-old man with long-standing type 2 diabetes and hypertension. He has multiple complications of diabetes, including retinopathy and neuropathy. And he has what I would characterize as progressive proteinuric chronic kidney disease. This is a graph of his estimated GFR over time, which is kind of how I think about kidney disease progression and kidney disease phenotypes in general. And you can see he's had a pretty steady decline in his estimated GFR from 70 a decade ago to now in the 30s when I saw him first in 2019. He had substantial proteinuria over this period of time with an albumin to creatinine ratio over 2,000 milligrams per gram when I saw him. And you can see that he was treated with metformin, glipizide, and insulin for his diabetes, amlodipine, hydrochlorothiazide, and hydralazine for blood pressure. He'd been taken off of lisinopril because he'd had a cough. And this patient, I think we would all recognize, is at high risk of progressive kidney disease. The best predictor of the future is the past, and he's been progressing. The high levels of proteinuria place him at great risk. And so this is a patient that in our clinic, we'd be very worried about becoming a statistics in terms of being a person with kidney failure or having cardiovascular disease before he gets there. So what are the options for prevention and treatment that we know about? And when I spoke 10 years ago, I spoke a lot about glycemia and glycemic control and how that is the foundation of prevention and treatment of kidney disease. And that is the case still today. I'm only going to spend one slide on it. And that slide is a summary of data from the Diabetes Control and Complications Trial and its observational extension, the EDIC Study. This is a study of type 1 diabetes that I've been fortunate to participate in. And the DCCT, as many of you will remember, took place from 1983 to 1993. And follow-up continues today, more than 35 years later. And on the left, what you can see here is how during the DCCT itself, and then in subsequent observational follow-up, intensive diabetes therapy, which was multiple daily insulin injections or a pump to reduce hemoglobin A1C as close as possible to normal, compared to standard glycemic therapy, how that affected microalbuminuria in the top row and macroalbuminuria, or an albumin excretion rate of 300 milligrams or more in the bottom row. And you can see there were large effects during the trial preventing those albuminuria outcomes. And the real incredible thing about the DCCT was what happened afterwards when observational follow-up was occurring and hemoglobin A1C was the same between the two study groups, yet there were continued differences and continued protection from the emergence of albuminuria that were as great or greater as during the trial for at least 8 years afterwards. And on the right, what you can see is the incidence of stage 3 chronic kidney disease, or a sustained estimated GFR less than 60 mils per minute, based on time since randomization in both the DCCT and EDIC trial. And what you can see is that during the period of the trial itself, which was on average 6.5 years, there were virtually no cases. But as observational follow-up continued, there was a large separation and a 50% reduction in the risk of low GFR with intensive diabetes therapy. So these data, I think, fairly clearly make the point that early on, at least in type 1 diabetes, good glycemic control has a powerful effect on the prevention of diabetic kidney disease and really is a foundation of care. I believe this also applies to type 2 diabetes, and similar results have been published from the United Kingdom Prospective Diabetes Study, or UKPDS. What we've learned from the more recent glycemic control studies like ACCORD and ADVANCE and the VA diabetes trial, which were conducted in people with type 2 diabetes and much longer standing duration of diabetes, was that applied late, there are little short-term benefits of tight glycemic control. It really is an intervention for prevention and for long-lasting future benefits. The other foundation of care that we have for diabetic kidney disease is, of course, renin-angiotensin system, or RAS inhibition. And these are two classic studies, now 2 decades old, looking at people with type 2 diabetes. And much like the patient I presented, proteinuric kidney disease with elevated creatinine, and randomly assigning them to an angiotensin receptor blocker or placebo. And each of these studies showed that compared to placebo and ARB, reduced risk of progressive kidney disease by 16 to 20%. And these have become standard of care as a result of studies like this. Again, like glycemic control, RAS inhibitors don't do everything. Other studies have shown that RAS inhibitors do not prevent the onset of diabetic kidney disease. And you can see from these cumulative incidence curves that patients who are at high risk, like the patient I had in clinic, even in the active treatment group, have still substantially high rates of progression to doubling the serum creatinine, end-stage kidney disease, or death, and additional therapies really are needed. So our group and others have looked about how these interventions have been applied in a systems way. And these are data from NHANES, serial snapshots from 1988 through 2014, looking at the use of these medications over time and their associated effects on intermediate markers. So on the left, you can see overall this period of time, increasing use of glucose-lowering medications in general. That's probably related largely to improved diagnosis and more stringent treatment over this period of time, with a fall in hemoglobin A1C. In the middle, you can see that RAS inhibitors were used more frequently over time, with drops in systolic blood pressure. And on the right, the increased use of statins with falling LDL cholesterol concentrations. There are a couple other things you can see about this. One is that these are nowhere near 100%. Now, they probably shouldn't be. Not everybody with diabetes has an indication for a RAS inhibitor or a statin, but many do. And these, even in 2009 to 2014, these proportions are probably lower than they should be. You can see that it's taken a long time to implement what are our foundational therapies. And you can see that there are disparities here by race and ethnicity. There are other disparities in implementation that have limited the optimal application of these drugs. And I'll get back to those near the end of the talk. So in the same study, we also looked at what was happening to the manifestations of diabetic kidney disease in NHANES over these periods of time. And the story is somewhat interesting, I think, in that on the left, you can see that albuminuria as one manifestation of kidney disease dropped, either microalbuminuria, shown as the total height of these bars, or macroalbuminuria is the, I think, more blue color down below. But at the same time, the prevalence of reduced eGFR, that's less than 60 mils per minute, increased, and less than 30 mils per minute also increased. For reasons that aren't entirely clear, some of which could be good, though, in that patients may be avoiding cardiovascular complications, avoiding mortality, living longer, and with diabetes and developing this manifestation of kidney disease. Overall, looking at any manifestation of kidney disease among people with diabetes, the prevalence over these 2 decades remained quite steady, unfortunately, between 25 and 30%. And this mirrors other data that have looked at diabetes complications in the United States over time. This is from Edward Gregg, who was at the CDC for quite some time. And he showed over a similar time period that, probably in part due to some of the intervention changes that I noted, there were marked decreases in risks of acute myocardial infarction, stroke, amputation, and on a smaller absolute scale, death from hyperglycemic crisis. But the one main complication that didn't seem to be getting better was kidney failure. So we hope that's going to change. And what seems to be a game changer in the diabetic kidney disease field really are the new glucose-lowering drugs that have been developed and tested in type 2 diabetes. And there was a major change by the FDA and the EMA in 2008, requiring that new drugs for type 2 diabetes undergo testing, not just for hemoglobin A1C lowering, but also for cardiovascular safety. And that change in regulation spawned a huge number of clinical trials, well-powered with clinical outcomes that have taught us a ton about new glucose-lowering drugs. Specifically, the incretin therapies, that's GLP-1 receptor agonists and DPP-4 inhibitors, as well as SGLT2 inhibitors. And I'll talk a little bit about what we've learned about the effects of those drugs on the kidney and how we can use those to control diabetic kidney disease. I'll start with SGLT2 inhibitors. These drugs work fundamentally on the kidney. Glucose is, of course, filtered through the glomerulus into the urinary space, and then in health, almost entirely reclaimed through tubular cells in the proximal tubule. There are 2 main enzymes and transporters that conduct this. The first is the SGLT2 transporter in the proximal tubule, and then just downstream is the SGLT1 inhibitor. And this is a sodium glucose cotransporter. So it's facilitated by co-absorption of glucose. It's present on the brush border of the membrane of the proximal tubular cells. Nephrologists have been inhibiting this enzyme for decades for physiology studies using a compound called fluorescein. And then more recently, drug companies have realized that this can be manipulated to make drugs that control glycemia by excreting glucose in the urine. And there are a number now of SGLT2 inhibitors that are available. There are also quite a few clinical trials that have been published with SGLT2 inhibitors. Here I've arranged them by population. There are 10 large studies that have been published, I think all of them in the New England Journal of Medicine between 2015 and the most recent two were just 2 weeks ago. And 4 of them were classic cardiovascular outcomes trials shown in blue. They all enrolled people with type 2 diabetes at high risk of cardiovascular disease and looked at major adverse cardiovascular events as outcomes. I classify another group of trials as CKD trials. These are trials that specifically enrolled people with chronic kidney disease based on the hypothesis that SGLT2 inhibitors would be beneficial for kidney disease. And these studies, at least 3 out of 4 of them, look primarily at kidney disease progression as outcomes. And then there's also a group of trials that enroll heart failure patients and look at heart failure admissions and other heart failure outcomes. This is another outcome that's markedly affected by SGLT2 inhibitors. And I won't go into great depth into all the trials, of course, but this is a summary by meta-analysis of the 4 cardiovascular outcomes trials and one of the kidney disease trials, CREDENCE, and showing some of the clinical effects of these drugs. There does appear to be a class effect, and these magnitudes of effect shown here, I think, are the best estimates of what these drugs do. They reduce major atherosclerotic cardiovascular events by 10%. So again, these trials were all initiated to demonstrate safety. They did demonstrate safety, and in fact, they demonstrated modest reduction in atherosclerotic cardiovascular events. On average, cardiovascular death was also significantly reduced by 15%. And then on the right here, you can see stronger effects on hospitalizations for heart failure, reduced by about 32% on average. And this is also similar to what's been found in the heart failure specific trials, and reduction of chronic kidney disease progression by 38%. So I should note at this point also, there are adverse effects of SGLT2 inhibitors. That is quite clear. The most common one are genital mycotic infections, which happen in about 2 or 3% of men and 5 or 6% of women who are placed on these drugs. They're usually treatable. There are also lower incidences of hypoglycemia. In general, SGLT2 inhibitors on their own are not very hypoglycemic because as blood glucose goes down, less is filtered and less can be excreted in the urine. Other adverse effects include diabetic ketoacidosis, which is rare in type 2 diabetes, though potentially severe and deadly, as well as volume depletion. So I'll highlight just briefly 2 trials that were particularly important for the kidney disease field. And the first one is CREDENCE. This is one of the CKD trials. It enrolled only people with type 2 diabetes who had proteinuria and randomly assigned them to Canagliflozin or placebo. It had a primary outcome of doubling of serum creatinine, end-stage kidney disease, or death due to cardiovascular kidney disease, similar to the Renal and IDNT RAS inhibitor studies I showed, and showed a highly significant 30% reduction in that primary outcome with a number needed to treat of 21. It also showed as a secondary outcome a 32% reduction in kidney failure on its own without the composite of creatinine elevations included in there. Another CKD trial was the DAPA-CKD trial of Dapagliflozin versus placebo. This also enrolled people with albuminuric chronic kidney disease. 2/3 of them had type 2 diabetes. 1/3 of them did not have diabetes. This study was stopped early for benefit and showed a 39% reduction in progression of chronic kidney disease, highly statistically significant. And I'll point out in these cumulative incidence curves that the effects are happening early. You can almost even see them at 1 year of therapy. And if you compare that to what I showed initially for glycemic control in general in type 1 diabetes, it's clear that this is having effects that are much more rapid than that seen for glycemic control on its own. And you can see in the box on the right that other cardiovascular and kidney outcomes were affected and improved in similar magnitudes to what I showed from the other studies. In DAPA-CKD, there was a slightly increased risk of volume depletion, which has also been seen in other studies. Perhaps the most impressive thing about DAPA-CKD was what happened in the third of people who didn't have type 2 diabetes, highlighted here. And even though the number of events in this subgroup was relatively small and the incidence rates were smaller than those seen in people with type 2 diabetes, the relative risk reduction was at least as strong in this group, suggesting that perhaps SGLT2 inhibitors are drugs that should move beyond type 2 diabetes and be used for other proteinuric kidney diseases. And that's a question that will still be addressed in other ongoing clinical trials. We're still scrambling to figure out why these drugs work so well in the kidney. Again, these trials started as safety trials. I think the large magnitude of benefit was unexpected by everyone. And so now we're working backwards to try and figure out why this happens. Some of the potential reasons are listed here on the left. First, these drugs do spill sodium and water in the urine. They're natriuretic, and they are accompanied by some weight loss and blood pressure reduction, which is a good thing. There's a hypothesis that I think does explain part of the mechanism here, and that's restoration of tubular glomerular feedback. And there's a hypothesis in diabetes called the tubular hypothesis that with excess glucose filtration, there's excess glucose and sodium reabsorption proximally here by the SGLT2 transporter, leading to decreased delivery of sodium in the tubule, activating suppressing tubuloglomerular feedback and leading to afferent vasodilation, higher intraglomerular pressure. And that by blocking proximal sodium and glucose reabsorption, you restore distal sodium flow, restore tubuloglomerular feedback, and lead to drops in intraglomerular pressure. And that's consistent with the clinical data we've seen here, for example, on the bottom right, from the EMPA-REG trial of empagliflozin versus placebo, looking at eGFR over time with an acute drop in eGFR upon initiation of SGLT2 inhibitor, followed by stabilization, a sort of pattern that we also see with RAS inhibitors. Personally, I don't think this is the only mechanism. I think there are other mechanisms involving work in hypoxia. I like the name beta blockers of the kidney by making them work less hard to reabsorb sodium and glucose, which by some accounts for 10 to 12% of energy utilization in the proximal tubule. You can reduce damage through that mechanism. And there are also clear effects on fuel metabolism, including shifts to ketone body and lipid metabolism in the heart and the kidney. Notably, for a number of reasons, the mechanism of protection is not through glycemia, not through blood glucose. And that's based on the rapid action of effect, the fact that these are very modest glucose-lowering drugs to begin with, and now the observation that they're working even in people who don't have diabetes. I want to say a few words about one of the other classes of drugs that's been studied, and those are GLP-1 receptor agonists. GLP-1 stands for glucagon-like peptide 1. It's secreted by the intestine when we eat. Its main effect is to go to the pancreas and stimulate insulin secretion that's triggered by glucose, amino acids, or other foods. So like SGLT2 inhibitors, it's on its own non-hypoglycemic because it only triggers insulin secretion in the presence of a stimulus. There are also effects on the stomach to slow gastric emptying and on the brain to reduce food intake, and these explain some of the side effects, nausea and vomiting, as well as some of the weight loss that's seen with these drugs. And as you can see, GLP-1 has effects throughout the body in pleiotropic ways, including on the kidney, where it affects, again, intrarenal hemodynamics. It also, though not as potently as SGLT2 inhibitors, causes a natriuresis, and it has effects on the renin-angiotensin system within the kidney, all of which may lead to beneficial kidney effects. The main benefits of these drugs in trials, however, has been on cardiovascular events. And in this meta-analysis, major atherosclerotic cardiovascular events were reduced by GLP-1 receptor agonists by 15%. And that effect was similar in people with normal kidney function, shown on the top here, as those with impaired kidney function on the bottom. There have also been beneficial effects demonstrated for all-cause mortality, on average 22% reduction, with similar effects with and without impaired eGFR. And the jury is still out on whether GLP-1 receptor agonists improve kidney outcomes. They do reduce albuminuria, but we're not sure yet whether they slow GFR loss. This is one study from Kathy Tuttle at the University of Washington in Spokane. It was a one-year study of dulaglutide plus aspart insulin versus glargine plus aspart insulin in people who had type 2 diabetes and stage 3 to 4 chronic kidney disease. It did reduce albuminuria, the dulaglutide versus glargine. It also appeared to reduce, to slow the progression of kidney disease over the short-term period with, shown here on the left, preserved GFR in the two dulaglutide groups versus placebo. That's summarized in the middle panel. And on the right is looking at categorical outcomes like seen in some of the larger trials I showed before, looking at eGFR loss or kidney failure. Low numbers of events in this relatively small and short trial, but clear trends towards dose effects with benefits of dulaglutide compared with insulin. So how do we take all this new data from all these exciting new trials and apply them to clinical practice? And that's a question that was directly addressed by a new clinical practice guideline on diabetes management and chronic kidney disease put out by KDIGO just 3 months ago. Many of you probably don't know what KDIGO is. It is really the guideline group for nephrology. It has an international audience. It publishes on everything from kidney disease staging. The new heat map that many of you are familiar with came from KDIGO, to transplantation, to anemia management, et cetera. And in 2017, just as some of these studies were starting to come out, they decided it was time to publish their first guideline on diabetes and chronic kidney disease. And it's taken 3 years, but here it is. And I was very honored that they asked me to co-chair this clinical practice guideline along with Peter Rossing, who's an endocrinologist at the Steno Diabetes Center in Copenhagen. And we had a really fabulous work group listed here. It's very diverse. It includes, in addition to nephrologists and endocrinologists, a cardiologist, a primary care physician, a pharmacologist, a nutritionist, and very importantly, 2 patients. And to my knowledge, this is the first time I've heard of patients being involved in a clinical practice guideline from the ground up. They were recruited from the very beginning. They had input into the questions we addressed and the way we phrased and presented the guidelines, and they were outspoken, and I think a very positive influence on the guideline. This clinical practice guideline was supported by an evidence review team, the Cochrane Group from Sydney, who took our clinical questions and performed systematic reviews and meta-analysis and generated data tables for guiding the guideline. This was really a labor of love. It's taken 3 years of work. I was impressed by how rigorous a process it was. And I hope that it's useful to the community. The guideline itself is chopped into 5 chapters listed here: comprehensive care, glycemic monitoring and targets, lifestyle interventions, anti-hyperglycemic therapies, and approaches to management. And the comprehensive care paradigm is summarized here in this pyramid with the idea that care should be based on lifestyle therapies, risk factor control, including glycemia, blood pressure, and lipid management, and then topped off with appropriately directed pharmacologic therapy. And the guideline contains 12 evidence-based recommendations using the GRADE criteria and 48 practice points. The practice points are meant to flesh out the recommendation and provide implementation guidance. There's no way I can go through all of these, but based on what I've been going through so far, I just wanted to highlight some of those recommendations in this one figure that actually includes 6 of the recommendations, 3 regarding lifestyle and 3 regarding drugs for metformin, SGLT2 inhibitors, and GLP-1 receptor agonists. And this is a central figure that provides an algorithm for selecting anti-hyperglycemic drugs for patients with type 2 diabetes and chronic kidney disease. And I should emphasize again that these newer drugs really are tested and approved for type 2 diabetes, not type 1 diabetes. And the algorithm, of course, I don't think this is controversial, suggests that lifestyle therapy should be the base of therapy, and that on top of that, drugs should be selected to reduce hemoglobin A1C and reduce the risk of long-term complications. And because of the exciting data that I present on SGLT2 inhibitors, the guideline suggests that SGLT2 inhibitors should be viewed with metformin as co-first-line therapy. And that's an elevation of the role of SGLT2 inhibitors given their profound benefits for kidney disease. There are recommendations for both of these drugs. For metformin, some may ask, why is it included as first-line therapy at all? Well, it is because it is effective at lowering blood glucose. It's shown benefits in the UK PDS study. It's inexpensive and well tolerated, and this is a worldwide guideline where not everybody across the world can afford expensive new drugs. So it is included as a first-line therapy. Most of you are probably aware of the risks of lactic acidosis that can occur, particularly when eGFR is low. So the guideline does recommend stopping metformin at an eGFR of 30. SGLT2 inhibitors are also recommended for initiation at an eGFR of 30 or higher. And that's because that was the threshold used for most of the trials that I've shown, not all of them. Some of them are pushing that limit down. Interestingly, most trials have allowed continuation of SGLT2 inhibitors when they fall below that level, and there is no safety concern like lactic acidosis for SGLT2 inhibitors as there is for metformin. And then the KDIGO guideline recommends that if people are unable to tolerate these medications or need additional medications for glycemic control on top of this base, we suggest a personalized approach to selecting those, but generally recommend GLP-1 receptor agonists as preferred, based largely on their cardiovascular benefits. The guideline does include a number of practice points for implementation of the lifestyle interventions and the drugs. Some of those are summarized here in a figure that's impressed at CJSON and covers fundamental issues like selection of drugs. And I should note that there's been no dose effect of these agents on kidney disease or cardiovascular disease progression. So in general, the lowest dose available that's been tested is recommended. There are recommendations for implementing sick day protocols and perioperative care to reduce the risk of diabetic kidney acidosis. Recommendations about what to do when you see an acute drop in eGFR, which is reversible and presumably hemodynamic, and the answer generally is don't worry about it. There are algorithms proposed for concurrent glucose management and volume management. And in particular, these drugs can be added fairly easily to existing regimens, though there are people at high risk of hypoglycemia or volume depletion for which concurrent medication should be potentially adjusted, and most importantly, follow-up should be arranged. And I'll note that we had in kidney grand rounds exactly 1 week ago a really fabulous multidisciplinary discussion about some of these issues of implementing SGLT2 inhibitors. We had Alec Mormon from cardiology visit. We had Chris Wong from primary care and Earl Hirsch from endocrinology. We had pharmacy involvement and a really fascinating roundtable about how to coordinate and streamline implementation across care. And I think it's recorded if people want to learn more about that and hear it. My last slide on the KDIGO guideline is here, and I just wanted to highlight two additional recommendations that the group made. And one was to implement a structured self-management education program for people with diabetes and chronic kidney disease. There are a number of objectives to such programs listed in the box below. And the second recommendation was a systems level recommendation to come up with systems level approaches to implement these guidelines, identifying appropriate participants or patients and applying drugs in other interventions appropriately. And these are recommendations that the patients in the panel were particularly insistent upon, and I think for good reason. And though not A levels of evidence, there was indeed evidence to suggest both of these. So I think that summarizes where we are, at least in October of 2020. So what's happening in the future? Where is this going? And this is a very rapidly moving field. And I want to comment on three items looking to the future. The first one I've mentioned a couple of times already, and that's implementation. And so in the field of diabetic kidney disease, we are very happy that we finally do have approaches to prevent and treat diabetic kidney disease. And I noted with RAS inhibitors, for example, that we've been slow and incomplete at implementing those. And I do think we need efforts to equitably and completely apply the evidence that we have generated to date. The second thing I want to bring up are additional therapies. So this is a very active area of investigation. There are emerging therapies in various stages. I'll comment on two other examples of drugs that have been tested in large trials, and there are many more in phase 2 trials coming up as well. The two examples, the first one is atrasentan, which is an endothelin antagonist. This was studied in 5,000 people with type 2 diabetes and kidney disease. It actually was a very interesting trial, the SONAR trial, in which it used an active agent run-in. So everybody who entered the trial received a fixed dose of atrasentan, and only people who responded and did not have adverse effects moved to randomization. It's an interesting design, a precision medicine sort of design. And response was defined as a short-term reduction in albuminuria of 30% with no fluid overload, because these drugs are known to cause edema and increased risk of heart failure. So about half of the people who entered the active run-in were eventually randomized. And what happened, interestingly, is in that selected group, the event rate was lower than expected, and the sponsor canceled the study. When they canceled the study, they closed everything out. They looked at the data, and it actually turned out that atrasentan compared with placebo reduced a primary outcome of end-stage kidney disease or doubling of serum creatinine by 35%, which was statistically significant. There was also a reduction in cardiovascular events. No one knows exactly what to do with this drug currently. There are other endothelin receptors in development, and there are ongoing trials with these, including combining them with SGLT2 inhibitors or other diuretics to reduce adverse effects. Another trial that I wanted to highlight is the FIDELIO-DKD trial, which was just published a few months ago. This was a placebo-controlled trial of finerenone, which is a new mineralocorticoid receptor antagonist with many similarities and some differences compared to spironolactone and eplerenone. It was another study of people with type 2 diabetes and kidney disease with a kidney disease primary outcome, which was reduced on top of RAS inhibitions by 18%. And there was also a reduction in cardiovascular benefits. There's an ongoing trial now called Figaro that is looking at finerenone for cardiovascular and kidney in the opposite order endpoints, which will give us more information on whether this is a robust finding. The third issue I want to address with regard to looking to the future is the potential role of precision medicine. And there are two things I think precision medicine can do. One is continue to develop the menu of treatments available to us by finding new drugs and targets. And the other one is coming up with better ways to select which of these drugs and interventions, assuming that our menu continues to grow, we should apply to individual patients. Precision medicine's been called applying the right intervention to the right person at the right time. And as we have more treatments available in the field, we need some guidance in doing that. So I'll spend the last few minutes of my talk before questions introducing the Kidney Precision Medicine Project and how it may affect diabetic kidney disease science and health. This is a summary of the rationale and design of the Kidney Precision Medicine Project, which is in press at Kidney International. And this is a visual abstract of that summarizes the approach. It is a new cohort study. It's enrolling people who have what we might call run-of-the-mill kidney diseases, including diabetes and chronic kidney disease, which I've been discussing, but also hypertension and chronic kidney disease, and acute kidney injury, which we oftentimes assume is due to acute tubular necrosis. And we tend to view these as fairly standard and unexciting kidney diseases. These people don't usually get kidney biopsies. But this cohort study is built around protocol kidney biopsies of just these patients. And the goal on the far right here is threefold. One is to create a reference kidney tissue atlas, so expanding upon cell types and their function and states in both health and disease to use as a research tool for investigators in all different fields. Also, to develop mechanism-based disease subtypes. So instead of relying just on albuminuria and EGFR to stage chronic kidney disease, for example, to move beyond that and try to understand across individuals which disease pathways are active and amenable for treatment. And then finally, to identify critical cells, pathways, and targets for novel therapies. And in the middle explains a little bit about how this will happen. There's an extensive clinical phenotyping performed at baseline at the same time as the kidney biopsy. The kidney biopsy itself undergoes traditional pathology as well as digital scanning with advanced digital imaging techniques. I'll talk about some of the multitude of omics evaluations that are being performed on the kidney tissue itself, and then these participants will be followed longitudinally for long-term clinical outcomes. This is the organizational diagram for the KPMP. We at the University of Washington are part of the central hub, which coordinates the activities of the KPMP. The three PIs of the central hub are Jonathan Himmelfarb at the KRI, Matthias Kretzler at the University of Michigan, Ravi Iyengar at Mount Sinai, and I work within the central hub as well. And we tried to direct the activities of a real broad national effort, which includes recruitment sites for both chronic kidney disease and AKI. There are 6 primary recruitment sites. There are a number of tissue interrogation sites to which kidney tissue is sent for molecular evaluation, and then other sites that also augment the clinical phenotyping and technologies available. This is a little bit about what happens to gather data from the kidney biopsy in the KPMP. Enrolled participants from the recruitment sites are biopsied usually always in a standard ultrasound suite or sometimes by CT. And then we're also adding, moving forward in 2021, laparotomy biopsies for patients who are getting laparotomies for sepsis. And in those settings, each participant there's a goal to obtain 3 kidney biopsy cores. First core is sent for standard diagnostic evaluation in clinical pathology laboratories, showing with the processing shown here, slides are generated. The local clinical pathologist generates a biopsy report, which is returned to the KPMP participant. Additional cores are processed using very rigorous and well-established protocols. We spent years developing these protocols, sent to the central biorepository in Michigan, and then distributed to tissue interrogation sites for analyses that I'll expand upon a little bit in the next slide. All of these data are compiled in a data lake, which is then elevated to availability on the web for researchers, clinicians, patients, etc. There's a lot we aim to do with the kidney tissue. Listed here are the omics technologies that are being applied. Not all technologies are applied to every kidney biopsy. There just isn't enough tissue, but there's a rotation, and these tissues are divided and sent across the sites. Some of the technologies use bulk tissue, for example, single cell and single nucleus transcriptomics, and this can identify specific cell types and the states of those cell types. Also used are microdissection techniques in which tubular interstitial segments and glomeruli are separated and sent for evaluation using proteomics or transcriptomics. There's a number of advanced imaging techniques that are applied, and after slides are scanned, we're using segmentation protocols to identify and quantify specific structures in light microscopy as well. The end goal is to integrate all of these technologies to generate functional kidney maps or the atlas. The KPMP started enrolling last fall. It was off to a good start. It was flatlined, as were many research studies in March when clinical and research resources were devoted towards COVID. We have started re-enrolling in the fall, and as sites have figured out how to safely continue these kidney biopsy and other procedures. We're now up to, I think, 58 biopsies in the consortium, about 2/3 patients with chronic kidney disease and 1/3 people with acute kidney injury hospitalized. And what have we observed so far? Well, we don't have any final findings yet. We're not a clinical trial, though. We don't have to wait until the end of the study to look at our data. And in fact, we review every single case from the KPMP in a session where the clinical case is presented, the pathology is presented, an adjudication is made as to the cause of kidney disease, which can then be used to differentiate molecular findings across kinds of chronic kidney disease. So we have continuously looked at the data that we have coming in, and the first important finding is that there have been no major adverse events through our first 57 biopsy. There have been hematomas, there have been drops in hematocrit with the kidney biopsy, but fortunately, nothing critical or disastrous. Another finding is that unexpected clinical diagnoses are fairly common. Now remember, these are on purpose participants who we expect to have common diseases. Nonetheless, we've seen a post-infectious glomerulonephritis, we've seen an oxalate nephropathy, we've seen some clinical diagnoses that were not expected. Even among the people who don't have such unusual diagnoses, which are the majority, we found that there's substantial heterogeneity in what we're seeing in the kidney, even between two people who have what we would guess would be similar hypertensive chronic kidney disease or diabetic kidney disease. And we found that our pathology vocabulary, which is really oriented towards understanding these severe clinical diagnoses, really is insufficient to describe the subtle differences that are likely important within these common types of kidney disease. Another finding is that we're finding a lot of action in the tubules of people with chronic kidney disease. This would be unexpected by many, because diabetic kidney disease has long been thought of as a primary glomerular disease, hypertensive kidney disease, largely a vascular kidney disease, but we're seeing a lot of action and a lot of heterogeneity in the tubules. And we're also finding that there's a lot of overlap between chronic kidney disease and AKI, more than I would have expected. And here's some data reinforcing that idea. These are single-cell RNA-seq data that have identified 9 different phenotypes of proximal tubular cells, you can see here. And then across 22, our first 22 participants, the relative abundance of these proximal tubular cells was quantified, and the participants then were clustered in rows here into 3 groups, 1, 2A, and 2B. And the main finding that I'm showing here, you can see what the clinical diagnosis was of these participants: diabetic kidney disease, AKI, diabetic kidney disease, hypertensive kidney disease. And the main finding here is that the clinical diagnoses are not at all correlated with the proximal tubular cell phenotypes. which is surprising since proximal tubular cells are substantially damaged in acute kidney injury. And in fact, when we take an agnostic approach, we don't see clear separation between that and CKD, again, suggesting that there's overlap in mechanisms between AKI and CKD. Another finding early on relates to participant feedback. So we have been very careful about informed consent and not over-promising what participants would get out of participating in this study. And most of the clinicians have immediately thought, well, there's not going to be a lot for patients to learn from this because it's not going to change our medication management. And so we've started prospectively surveying participants about what they're getting out of the study. And in fact, here in the middle, you can see at 4 weeks after kidney biopsy, the majority of participants have not changed their medications because of their kidney biopsy. 9 out of 11 said no changes. Though 6 months later, the majority are reporting, 10 out of 18, that they have made some changes to their medications based on their kidney biopsy results. More are reporting that they're making some changes based on their kidney biopsy to supplements, complementary alternative medications, their diet, or their physical activity and exercise. And also, even more, our participants are reporting changes in knowledge, including changes in how they think about their kidney disease, how they talk about their kidney disease with families and friends, and their prognosis, what they think about their kidney function in the future. And these last questions are questions I wouldn't have even thought to ask. They're questions that were motivated by patients within the KPMP. And like the KDIGO guideline, the patients have played a critical role in the KPMP. They've been involved from the very start, considering the ethical issues of research kidney biopsies. They've been involved in the organization and all of our committees and in our steering committee as well. They've contributed to informed consent process, and I just showed an example, one of many, of how they contributed to the protocol and the information that we're gathering. KPMP is a 10-year horizon. We're just in the beginning of year 4 right now. We have a constant reevaluation of protocols and adaptation over time, but we've completed the initial phase of protocol development, and we're now in what we call phase 2, where we're enriching a kidney atlas, expanding our cohort studies, really recruiting, and we hope this will continue for at least 10 years into the future as we accumulate participants and data. Where will KPMP lead? Well, I do hope it will lead to identification of new pathways, targets, et cetera, for interventions. And with regard to where I started, which is selection of drugs and clinical trials, I think and hope that it will lead to a new approach to clinical trials. Perhaps this could be considered an oncology model for clinical trials, in which people with diabetes and kidney disease could be phenotyped either using a kidney biopsy or a liquid biopsy, as some people like to call it, blood and urine biomarkers that correlate with kidney tissue. Patients at high risk of kidney outcomes could be selected for enrichment of clinical trials, and then ideally based on pathways activated in the kidney biopsy or liquid biomarkers. Those patients can be selectively assigned to appropriate clinical trials or simply treatment agents. So I'm going to go back to the case that I started with, this veteran with progressive proteinuric chronic kidney disease. There were a number of changes that I made in his care after he was referred. First, I did add losartan, the ARB approved at the VA formulary, which was tolerated well. I think that's when his eGFR ticked down a little bit here. I subsequently, with the help of our pharmacy colleagues, added empagliflozin, which is, I think, what led to this larger decrease in eGFR, which did not concern me. I did continue the empagliflozin, though I think at this point I stopped his metformin. And I talked with him a lot about education for kidney disease planning, as we always do, and also the importance of self-management. And of course, at the VA, we're always looking for ways to improve our systematic care of these patients. So some concluding thoughts. Diabetic kidney disease is a growing public health priority based on the epidemiology I started with. Glycemic control and RAS inhibition remain the foundations of prevention and treatment. SGLT2 inhibition is now also standard of care for type 2 diabetes and chronic kidney disease. I meant to mention, but forgot that this is actually the KDIGO recommendation is consistent with that of the American Diabetes Association, which also suggests adding SGLT2 inhibitor to metformin for people with CKD, regardless of glycemia. There are additional treatment options that are emerging, and precision medicine, I think, offers a promising path forward, both to tailor treatments and to identify new and complementary therapies. So I've gone longer than I anticipated. I was verbose today, but I'd like to thank my colleagues at the KRI, all the participants and co-investigators of the studies I mentioned, and the KDIGO staff and work group for the guideline. And thanks for listening. I hope we still have some time for questions.
Absolutely. Thank you so much. That was a fantastic talk and really exciting to hear about this precision medicine project and where things are headed, hopefully in the near future as things pick up again with research. I see at least one question in the chat, and feel free to send some more. Looks like also potentially a hand raise in the audience.
I can start with the question in the chat from an excellent one from Carol Baumstick. No surprise, given the heterogeneity, how many biopsies will you need to gain omics information useful in the clinic? We don't know, and we don't know what sort of heterogeneity we'll see between biopsies, between diseases, and between diseases and outcomes. The KPMP is targeting 200 biopsies in its first 5-year period with an assessment of what that heterogeneity looks like. And then we will try and make some power calculations to determine exactly that question. But nobody's done this in this way, and we just don't have the data to make a conclusion there yet.
I see another question. Thoughts on primary care doctors prescribing ACE inhibitors for lower GFRs?
Yeah, so there are some studies ongoing looking at particularly stopping ACE inhibitors in people with low eGFR. I will say that it's the people who have high risk of kidney disease progression because they have albuminuria and because they have low eGFR who we think benefit the most from ACE inhibitors. So when we can, unless we run into untreatable problems with hyperkalemia, for example, we do want to prioritize those patients. I think primary care physicians should be helping with that. If it does get into questionable situations with complications, I think that's like hyperkalemia, that's a time to get nephrology involved. I think for all of these medications and all of the therapies that I've talked about today, in order to implement them widely, we need not just nephrologists to be prescribing them, but primary care physicians in particular, cardiologists, pharmacy colleagues, all sorts of people.
Another question, how do you see other novel therapies for diabetic kidney disease being used in combination with SGLT2 inhibitors?
Yeah, it's a great question. Thank you, Nisha. So it's hard to know. And we could take a cardiology approach of layering therapies on top of each other, which is, to my view, worked quite well for heart failure. Many of these medications do have hemodynamic effects that reduce intraglomerular pressure and low GFR. There may be a limit to that. Most of the trials have not studied combinations. I didn't mention most of the SGLT2 and GLP-1 receptor agonist trials were on the backbone of metformin. The finerenone was on top of an ACE or an ARB. But the multiple combination agents have not been studied. And I think we will need studies of those combination medications, short-term and long-term. And then ultimately, of course, as I said, I'd love to have a precision medicine approach to better target.
A few questions. One specifically about the challenges in omics data, especially collected in this context, the sort of way that noise can play a role. What strategies are you using to sort of mitigate that?
Yeah, that's a fabulous question. And in the KPMP, quality control is a huge effort, and it spans all phases of the KPMP, from the clinical data and biospecimen collection, but then particularly at the level of the tissue and making sure and looking at assay drift and shift among what are really discovery technologies. It's a huge challenge. It's something we're still working on. And then you also mentioned data management. So this is a huge amount of data, even though we only have 57 people so far. The amount of data on each of these is a bit mind-boggling, and keeping that under control. The versioning and the releasing of that to the public is a huge undertaking, and probably merits an hour talk on its own. Not by me. That's not my area of expertise, but it is a huge effort.
A couple people asking about SGLT2 inhibitors in the type 1 diabetic population. Any comments on that?
Yeah, one of the big questions, even broader than that, is beyond the type 2 diabetes population. Who can use SGLT2 inhibitors? In type 1 diabetes, they're likely to be just as effective. There's no reason to believe otherwise, but the problem is DKA, and SGLT2 inhibitors increase production of ketones, and in a setting where insulin is insufficient, that overproduction combined with insufficient insulin can readily lead to a life-threatening diabetic ketoacidosis. So I believe one SGLT2 inhibitor is improved for a subset of specific type 1 diabetes patients in Europe, but not in the US. Our recommendation does not include type 1 diabetes. I know some patients are using it off-label, those who think they're able to monitor for and prevent diabetic ketoacidosis in particular, but that's not standard of care currently. Other populations that may benefit from SGLT2 inhibitors include transplant recipients, kidney transplant recipients, not included in the KDIGO recommendation because of immunocompromised state and potential risk of infection, but maybe very promising. More advanced EGFRs, lower EGFRs, and other populations too.
I think maybe time for one more question, which is sort of what role does albuminuria or serpirtinuria fit into the diagnostic and therapeutic decision making, specifically with SGLT2 inhibitors?
Yeah, it's a great question. It fits in a couple of ways. First of all, RAS inhibitors are proven only really for people with albuminuria. Those are people who are at high risk of progressive kidney disease and need RAS inhibitors for prevention of kidney disease progression. Absent albuminuria, there are other antihypertensive agents that can be used to prevent cardiovascular events. For SGLT2 inhibitors, patients who have a normal GFR and albuminuria are certainly candidates for SGLT2 inhibitors. They're at risk of heart failure, kidney disease progression, cardiovascular disease, and in that group, those risks are prevented by SGLT2 inhibitors. In fact, across the spectrum of albuminuria and across the spectrum of EGFR, SGLT2 inhibitors seem to have consistent beneficial effects on these outcomes. And I think Mike is referring to the increasingly common phenotype of diabetes with low EGFR, but normal urine albumin, and the kidney and cardiovascular benefits are maintained in that group of people with type 2 diabetes as well. And so our recommendation in my clinical practice is to treat those patients with SGLT2 inhibitors as well.
Thank you so much. I think we're at time. Thank you everyone for your time and your wonderful questions. This was a really excellent talk, and I'm excited to see where the state of the art moves with this new venture into precision medicine. Thank you everyone, and have a great rest of your Friday afternoon. Thank you.
Thanks for having me.